and welcome to our BiteMedicine webinar this evening on urological malignancies. My name is Georgina Hambry and I am a medical trainee currently working at St Mary's Hospital in Paddington, and I'm joined this evening by a major trauma clinical fellow, Marta, who's kindly come to share some of her expertise with you this evening. The aim of the session is to give you some background into the epidemiology, the pathophysiology, the clinical features, investigations and management of three important urological malignancies, these being prostate cancer, bladder cancer and kidney cancer. We hope by giving some both theoretical background regarding these malignancies, it will help in your preparation both for exams and also the start of your working lives as junior doctors on the wards. As we go through, there'll be a number of questions, and we'll just pause during that time to give you an opportunity to think through what your approach to the answers would be, and just help build your knowledge regarding this subject area. So I'm going to start by focusing on prostate cancer, and then Marta's going to go on to talk to you about bladder and kidney cancer as well. So as many of you I'm sure already know, through BiteMedicine there's lots of questions and resources available, as well as the online textbook. So just to get us started in the first instance, if you want to have a think about how common you think prostate cancer is in the UK, is it 1 in 8 men, 1 in 20, 1 in 55, or 1 in 200? So I'll just give you a minute just to have a little think or scribble down what you think might be the answer to that opening question. So prostate cancer is very common. It's the most common cancer in adults, in adult males in the UK, and it's the second most common cause of death due to cancer in adult males after lung cancer. And the answer to this first question is 1 in 8. So 1 in 8 men statistically will develop prostate cancer at some point in their lives. So just a little background about the epidemiology. As I say, it's the most common male cancer in the UK, with an annual incidence of 47,000, with prostate cancer related deaths affecting 11,000 on average men each year. It is also responsible for a quarter of all new cancer cases diagnosed across the UK, and predominantly it's a malignancy of older men, typically developing in the 70s or later. So just to have a think about the risk factors for prostate cancer and what those things are. Increased age is a really important risk factor for prostate cancer, as is family history, and there is a familial association within about 5 to 10% of cases. Some ethnicities are more susceptible to developing prostate cancer, and these include Afro-Caribbean patients in particular. Some lifestyle factors are relevant here, and obesity and a high-fat diet have, in some of the literature, been shown to increase the risk of developing this condition. And there's other exposures, as written here, that may also contribute to an individual's overall risk. So just having a think about the pathophysiology of this malignancy, the most common type of prostate cancer is adenocarcinoma, and it commonly arises from the what we call the peripheral zone of the prostate. And there are some genetic associations, like with BRCA1 and BRCA2, which a lot of you, I'm sure, will know is linked with some cases of breast cancer. Now, the typical mode of spread of prostate cancer occurs along the capsule of the surface of the prostate, so local invasion, or via the lymphatic or hematological systems. Having a think about the symptoms of prostate cancer, I'm sure if you just take a minute to consider what some of those are, if you think just practically where the tumour is developing through compression with the tumour growth, it is likely to cause a number of symptoms. So you have local obstructive type symptoms resulting from the tumour compressing on the urethra, and this can cause problems such as hesitancy, poor urinary stream, a feeling of incomplete bladder emptying, amongst others. It can also cause symptoms that can replicate infective type symptoms such as hematuria, dysuria, for example. And beyond that, they can be more systemic features, which are important to be aware of. They make, and these are similar across other different types of cancer as well. So general lethargy, a lack of energy, anorexia or reduced appetite, and also symptoms of spread of the disease. So, for example, here you see lower back pain as another possible feature of prostate cancer in the metastatic setting, as prostate cancer quite typically metastasizes to bones, including the spine. So these are just a number of different areas you can sort of keep in the back of your mind when you're clerking a patient in A&E or you're looking after a patient on the ward. So just to sort of break this down more systematically, thinking of the signs and symptoms that you want to be aware of. So the common obstructive lower urinary tract symptoms, including the frequency, hesitancy, nocturia, patients often getting up several times a night to pass urine. And as I'm sure you know, lots of these symptoms will also be present for benign prostatic hyperplasia, and I guess that's often the difficulty, is trying to determine whether this is a benign process or a malignant process, and that's why we often go on and do more detailed investigations to get to the bottom of that. Less commonly, you can also develop symptoms of hematuria or pain passing urine, and others evidence of bone type pain as well. In terms of signs, these are, so what as a clinician you'll be trying to pick up at the bedside to sort of put into your clinical picture as to what you think might be going on. And this, you may detect an abnormality when you're performing a rectal examination in clinic or on the ward. If there's some lymphadenopathy palpable on examination, this is indicative of a metastatic disease. And urinary retention, if a patient is unable to pass urine, have very severe suprapubic tenderness, for example, this may also be a sign that there is a downstream obstruction, and there are a number of possible causes for urinary retention, and this is one such example. So just to move on to another question, so which of the following is true regarding a PSA test? So a PSA being a prostate-specific antigen test, which is a blood test. So so out of these, which do you believe is true? So a raised PSA indicates prostate cancer. A normal PSA rules out prostate cancer. A PSA can aid detection of asymptomatic prostate cancer, or a very high PSA level negates the need for further investigations, such as a biopsy. So just take a minute to have a little think which of those you think is most likely to be. So here, the correct answer is it aids detection of asymptomatic prostate cancer, and is a very useful tool, particularly because prostate cancer can be really have no symptoms in the early stages of the disease. So just to have a think about how we go on and investigate this condition, I've just broken these down into the two key areas of investigations that is important to be aware of for prostate cancer, and these are our blood tests and our imaging. So in terms of the blood tests, it's a prostate-specific antigen, as we've just discussed, and bone profile as well is really important. This can be high, and this can show high levels of calcium and ALP as well, which both a picture such as that is really suggestive of bone metastasis, and will encourage you to think about further imaging to identify whether bone involvement is indeed present. Other relevant blood tests include liver profile, looking for any disruption in the liver functioning, which may suggest metastatic spread of disease, and a renal profile as well, to try and determine whether obstruction of the renal system has resulted in back pressure and renal damage, and again might suggest prostate cancer. It's also relevant in the in later down the line when we're considering appropriate management as well, because patients need to have sufficient organ function, including kidney function, to be amenable to certain types of management, including chemotherapy. So it's a really crucial investigation. Moving on to imaging, MRI is a really important imaging modality for the prostate, and used routinely in this setting. If, for example, you noted a high calcium or ALP, you would certainly be going on to do an isotope bone scan to look for any site of bone involvement. Similarly, to help us decide on the staging of the malignancy and therefore the approach to management, a CT chest, abdomen and pelvis is performed in this setting to look for any other sites of disease. So the advantages of the PSA is that, as I said, it can pick up prostate cancer before symptoms occur, and by doing so can help us intervene at an earlier stage before metastatic spread, and therefore will have a much greater chance of achieving disease control. Having regular blood tests can also help pick up prostate cancer amongst more high-risk groups, and any changes in the PSA level is also a very useful marker of monitoring disease and changes in someone's pattern of disease. There are disadvantages of the PSAs, so though it's a useful tool, we shouldn't it's not the sole determinant of how we perform our management for patients. It can miss prostate cancer, so that's always something to be in the back of your mind. A normal PSA doesn't absolutely confirm that this patient doesn't have a prostate cancer. 15% of people with a normal PSA may have prostate cancer. So just an awareness of that, I think, is really important clinically and practically when you're on the wards and looking at blood tests. 2% with a normal PSA may have a fast-growing and potentially rapidly advancing prostate cancer. So again, we mustn't take too much reassurance. We need to take this measure into context, and also I think it's important to mention that the PSA might mean we pick up very early disease and very slow growing disease in, for example, frail elderly patients in whom they are very likely to eventually die of a condition other than their prostate cancer, and therefore the downside being that you're having to give a serious diagnosis without necessarily needing to do any formal treatment, because it may not actually be appropriate in that setting. So here's just an MRI image of the prostate, and as you see the anatomy in this image here. So I'm just going to talk briefly about the scoring of prostate cancer, and this is done with Gleason scoring, which was named after Dr. David Gleason, who was a clinician working in the 1960s, who this scoring system is named after because they realized that cancer cells fall into 5 distinct patterns as they change from normal to cancerous cells. And this scoring system is used to grade prostate cancer when we've taken a biopsy, and the overall score is ranges from 2 to 10, and it's identified, it's calculated by identifying the most prevalent histological pattern and grading this from 1 to 5. 5 being the least differentiated and therefore the most severe or abnormal or cancerous. The second most prevalent histological pattern is graded in exactly the same way, and these two scores are then added together and you get an overall score. And this is relevant because it helps us both guide our management and give us some information regarding a patient's likely prognosis as well. So just here is an outline of the pattern of changes, as you see. So in number 1, the cells are really pretty uniform and almost resemble normal healthy tissue, and as you go down to number 5, the cells are grossly abnormal, as you see, and that's very worrying because that's very abnormal changes and are suggestive of more severe disease. So in terms of management, there are multiple approaches to management. We can do nothing at all, actively watch patients, active surveillance. We can perform radical surgeries, radiotherapy, give hormone treatment, or palliate or give best supportive care in the case of advanced disease. So here you see a robotic piece of equipment for robotic surgery, and a diagram related to radical prostatectomy here. So just to run through the management, so for low and intermediate risk cancer, we may actively survey patients in this cohort who are frail elderly patients with slow-growing benign or slow-growing disease, which may not be causing problematic symptoms. We can consider radical prostatectomy with surgical removal. Often this is performed robotically, or radical radiotherapy or brachytherapy with hormone treatment on top. And radiotherapy in this instance is usually performed over approximately 2 months. And brachytherapy is where the radioactive seeds are implanted into the prostate. And this can be given in combination with hormone therapy. So for high risk or localized, high risk cancers that are localized, we can do again a radical prostatectomy and also consider dissection of the lymph nodes. We can give radiotherapy, again we can give brachytherapy, or in some cases we can give chemotherapy with hormone treatment as well. In the metastatic setting, it's chemo, it's hormones, primarily is the management of choice. So in surveying patients, we would regularly perform PSA monitoring and look for any increases or changes in both the value of the PSA and also the rate at which it is changing. We can do monitoring via imaging with an MRI, and it's important to bring in the multidisciplinary team and make sure they have contact and support from specialist nurses. Complications can relate to both the cancer itself or the procedures or treatment which they are given. So cancer-related complications include retention and metastatic disease, and other complications relating to treatment include surgical complications and or radiotherapy complications such as bloody diarrhea that you can get following the radiotherapy affecting the lining of the colon, to name a few. In terms of the prognosis of prostate cancer, in the vast majority of cases, the overall 5-year survival is very good and is up to 100%. So thank you very much for listening. I'm now going to pass you over to Marta, who's going to do the next section of the talk. So I'm just going to stop sharing my screen and let Marta take over. Thank you very much for listening.
Hi everyone, I'm Marta. Let me just share my screen quickly. Just a second.
Marta, are you there?
Yeah, thank you so much. Okay, everyone, so I will start by taking you through renal cell cancer. And it's a really important one to talk about because it's actually really common. So in 2017, it was the 10th most common cancer in females and the 6th most common cancer in males. And in this picture, you can actually see that those tumors can grow to quite large sizes. Can we move to the next slide, Regina? So this is just something to start you off and have a think about, what is the most common subtype of renal cell cancer? So is it clear cell cancer? Is it papillary, chromophobe, or the renal medullary cancer? If you just take a few seconds to scribble it down. Okay, should we move on? So in this case, the most common one is clear cell cancer, and it accounts for around 75% of all renal cell cancers. So just a few things to be aware of. You can also see it being called a hypernephroma, and renal cell carcinomas in themselves account for around 85% of primary renal neoplasms. They normally arise from the epithelium of proximal renal tubules, which I'm sure you would recall play a very important role in maintaining the pH of the filtrate and basically keeping balance of salts and important electrolytes. And as we already said, the most common histological subtype is the clear cell carcinoma. Yeah. So just a few things regarding pathogenesis. So renal cell cancer is a type of adenocarcinoma. So the cancer arising from the lining, epithelial lining. It is the most common variant of the renal cell cancer is the clear cell carcinoma. And that would be, as we already said, 75 to 85% of the bulk of the disease. The majority of the cases are actually sporadic and are due to deletion of von Hippel-Lindau tumor suppressor gene. And therefore, a very small minority of the cases will be hereditary and will be associated with the von Hippel-Lindau syndrome or with tuberous sclerosis. So renal cell cancers actually have quite a lot of important endocrine associations. And this is due to, if you think about kind of the importance of kidneys and of the adrenal glands, so surrounding structures on maintaining this endocrine balance, you would hopefully appreciate why it can be distorted by the carcinoma of the renal cells. So to start with, you can see the increase of erythropoietin, which can lead to polycythemia. And you would recall that physiologically, basically, erythropoietin is produced in response to tissue hypoxia. And this is basically to promote differentiation of colony-stimulating units in bone marrow to produce more red cells. However, in the renal cell cancer, the substance itself is produced by the tumor cells and also by the cells that are being compressed by the tumor. Another important association is the parathyroid hormone-related peptide, which is something very specific for the renal cell carcinoma, and it can lead to hypercalcemia. So basically, this parathyroid hormone-related peptide would then bind to parathyroid hormone receptors in bone and renal tissue, and in turn, that would increase bone resorption and decrease calcium clearing kidneys, which in turn gives you hypercalcemia. So you could have a patient who would also complain of lethargy, nausea, confusion, weakness, constipation. If you were to do an ECG on a patient with hypercalcemia, you can initially note some prolonged PR interval, leading to bradycardia or even asystole in extremes. And I think whenever we talk about hypercalcemia, it's actually really important to notice that it can be even non-metastatic, such as due to parathyroid hormone-related peptide, but you can also have increased calcium due to bony metastases related to cancer itself. Another important association is the Acdh, and this is basically produced because the tumor cells themselves promote the basic conversion of the precursor to Acdh into the active form of Acdh, and then this would drive the cortisol secretion in adrenals. And as a result, you can get Cushing syndrome, which I'm sure you would recall from your endocrinology, could lead to patient presenting with weight gain, typical appearance of sort of buffalo hump, fragile skin. They would have some stretch marks on the skin. They can complain of weakness, cognitive dysfunction. And finally, you can see increased renin secretion in renal cell cancers, which would in turn lead to increase in blood pressure through the renin, angiotensin, aldosterone system. So renin can be secreted in the neoplastic cells themselves, but also due to local stress compression effects on the parenchyma. So this is quite a lot to go through, but I think it's really important to understand also why those endocrine changes happen. And can we move to the next slide? So this is just a little briefer. So in this picture, you can see basically a prosection of the kidney, and you can see a about 8 centimeter renal cell carcinoma that is extending from the lower pole of the kidney beyond the cortex. And on the histology, it was found that it was actually clear cell renal cell carcinoma. Should we move to the next one? Thank you. Yeah, so as you can see, basically you can have, this picture basically shows you that normally your kidney tumor would arise from a particular area of the kidney, and then it can be graded depending on how it spreads throughout. Can we move to the next one? So going through the different subtypes, as we already said, the clear cell carcinoma is the most common subtype, accounting for 75 to 85%. There are a few important ones to be aware of. Papillary tumors are the second most common ones, and they actually can present in both kidneys, can be bilateral in up to 1/3 of the cases. Then you have the chromophobe and multilocular cystic cystic cancers, and both of those have actually really good prognosis. And then finally, you have your renal medullary cancers, which are very aggressive, and actually a lot of your patients would have metastases at presentation. So let's just go through a couple of risk factors. As we already said, renal cell cancers are really common. They are the 10th most common cancers in women and the 6th most common cancers in men. The incidence increases with age, and it peaks around 60 to 70 years old. It presents a 3-to-2 ratio of men to women, and it's more common in sort of Black ethnicity. We already discussed that some of the cases can be hereditary and can be associated with conditions such as von Hippel-Lindau syndrome or tuberous sclerosis. It is also like most of the cancers quite heavily associated with smoking, which when you're seeing the patient, it's actually really important to have in mind that it's actually a great modifiable risk factor. It's also associated with obesity, hypertension, and hemodialysis. And actually the risk of renal cell carcinoma increases proportionally with the length of the hemodialysis. So just something for you to think about. How does renal cell cancer most commonly present? What do you think the patient would come and complain about? Whether it would be abdominal mass or loin pain, hematuria, weight loss, or maybe they would come and have no symptoms at all. Just take a few seconds to have a think about that. Okay, so thank you. All of the symptoms is something that the patient can complain about and can present to you with. However, the most commonly those patients actually do not have any symptoms, and the condition can be picked up incidentally. Should we move on to the next one? Thank you. Okay, so another question, just to let you think about it. So there is something called classical triad of the renal cell carcinoma. The three symptoms that are basically seen or are described as common in the condition. So for you to think about, is it hematuria, abdominal mass, and weight loss? Hematuria, flank pain and fatigue, flank pain, fatigue, and varicocele, or hematuria, abdominal mass, and flank pain? Okay, so the classical triad of the renal cell carcinoma, something that you will hear about quite a lot, is the patient presenting with hematuria, abdominal mass, and a pain in the flank. The important thing to be aware about is that those three symptoms are actually present initially in about 10 to 15% of patients. So it's something to be aware of, but you always need to have, as a clinician, a high index of suspicion and be aware that patients can present in many different ways. Okay, thank you. So clinical features, just to make it a bit more systematic. As we said, the clinical triad, hematuria, loin pain, abdominal mass. Those patients can actually present with fever of unknown origin, and this can be either a presentation or they can actually complain of having pyrexia before they presented. And men can present with left varicocele. And this is due to occlusion of left testicular vein. So you would recall that your left testicular vein would then drain to your left renal vein. And when the renal cell cancer spreads, it can actually cause the back pressure and occlude the left testicular vein. This is something to be very aware of. And whenever you would see a man presenting acutely with left varicocele, you really need to have a high index of suspicion. Okay. And just to go again for sort of symptoms and signs. So as we said, over half of people would be completely asymptomatic at diagnosis. And the diagnosis would be picked up incidentally, whether there will be doing a different scan or there will be something else in investigations when you would actually feel quite worried about. We already discussed the classical triad of hematuria, flank pain, abdominal mass. And as we already said, you need to be very worried that only a small proportion of patients would have all those three symptoms at presentation. And as with any other malignancy, your patients can suffer from some constitutional symptoms such as weight loss, fatigue, or fever of unknown origin. When we move to the signs, if you were to examine patient, you could find a palpable mass in the flank, In a male, you will find left-sided varicocele. And just to be aware, this varicocele is always left-sided. Your right testicular vein drains directly into inferior vena cava. Therefore, the right-sided renal cell carcinoma would not cause varicocele. Patients could also present with hypertension, and as you would recall, this can be due to endocrine effects of increased renin secretion, as we already discussed, and this is also a risk factor for the condition. And some of the patients actually present with evidence of the metastatic disease. So some of them could be short of breath at presentation due to pulmonary metastases. Some of them could have chronic liver disease, or can present with bone pain, which is highly indicative of bony metastases. Okay. So if you were to investigate your patient, you would start off by doing urinalysis, a urine dip, and you could pick up microscopic hematuria or proteinuria. Then you would progress doing a set of bloods. So on your full blood count, you could either find the patient is anemic or polycythemic. And just to mention, we already discussed about the effects of erythropoietin and how it can cause polycythemia. However, quite a significant number of those patients would present anemic, and this is because they would have anemia of chronic disease, because it's always about a balance between sort of bigger picture of what's happening in the body as a whole and how the condition affects it. If you were to do UNEs, you would look to basically assess the renal dysfunction. You would want to do LFTs and coagulation profile to look for any derangement that could suggest liver metastases. You would then go on doing a bone profile, looking for elevated calcium, which is a poor prognostic marker and may also suggest bony metastases. And a number of these patients would have elevated ALDH, which is a very poor prognostic marker for the condition. And as we already said when talking about prostate cancer, it's important to have those baseline tests also to basically assess the general condition of the patient to help you guide the management and see what will be the most appropriate for the patient. You would then move on to doing imaging. So you would start with doing abdominal ultrasound, which can give you an idea of the tumor. However, it always needs to be followed with CT abdomen and pelvis with contrast. And this is a definitive test for diagnosis, which is highly sensitive and highly specific. Few investigations to consider is CT chest for staging, for let's say for any metastases. And if you're concerned about evidence of bony metastases, such as symptoms of pain or hypercalcemia, you would do a bone scan. Biopsy is something that's not commonly done, and this is because you go into risk of actually spreading the tumor into surrounding tissues when you take a tissue sample. However, it can be considered after a careful multidisciplinary team discussion. Okay, so kidney cancers are generally staged into 4 different stages. Your stage 1 is really confined tumor, which is less than 7 centimeters small. Stage 2 tumor is a significantly larger tumor, over 7 centimeters. However, only going to stage 3, your tumor will start growing to major veins in the kidney. It can invade perihepatic tissues, but very importantly, it does not spread into the adrenal gland. And stage 4 tumor is a tumor which is basically growing and breaching the connective tissue encapsulating the kidney, and it can also extend into adrenal gland. Okay. So a number of cancers can cause metastases to lungs, and those include breast cancer, renal cancer, bladder cancer, and prostate cancer. However, what is quite specific for for renal cell carcinoma are those cannonball metastases, which you can see on the X-ray on the left as basically rounded, well-defined opacifications. They can also occur due to secondary to choriocarcinoma or prostate cancer. And actually, if you were to look at the CT scan on your right, you can see a tiny arrow pointing to a lesion, which is another cannonball metastasis. Okay. So let's just have a think about the management of the renal cell carcinoma. And it's really important to think about how you manage the localized disease and a disease that has spread to other parts of the body. So for a low-grade tumors, which is practically the T1 marked tumor, which you would recall is a tumor that is smaller than 7 centimeters and has not really breached the connective tissue or not grown into any veins. Very often partial nephrectomy is performed, and it's done with the curative intent, so the intent to actually treat the patient from the condition. Radical nephrectomy, which basically means dissecting the kidney, dissecting local lymph nodes, and also performing adrenalectomy, is something that's standard for higher grade tumors. There's a number of minimally invasive procedures, such as radiofrequency ablation or embolization, but this is generally reserved for patients who are unfit for surgery for a multitude of reasons, whether that is the other medical comorbidities. So when you think on metastatic disease, there's again a number of treatment modalities. Something that's really changed the outlook of renal cell carcinoma is molecular therapy. So sunitinib and pazopanib are the receptor tyrosine kinase inhibitors, and they're generally first-line treatment agents. And they have been found to be superior to interferon alpha in management of renal cell carcinoma. Some of the patients are suitable for radiotherapy. However, a number of those will be palliative. And you can also perform a cytoreductive surgery. Some of the patients would be suitable again for debulking surgery and for non-curative nephrectomy. However, there has been evidence that even though this approach is not really aiming to cure the condition, it has actually shown the improvement in survival. Okay. So just again, something to get you thinking about. Can you think about some complications of the renal cell carcinoma? So the options we have is hypertension, hypercalcemia, liver and spleen problems, metastatic disease, or actually all of the above. Also, for this question, the answer is actually all of the above. So renal cell carcinoma can lead to a number of complications or derangements in your body. We already discussed about hypertension, hypercalcemia. This is due to endocrine effects. You can actually get liver and spleen problems, and also disease can metastasize. If we go to the next slide. Thank you. Yeah, so renal cell cancers commonly spread to adrenals, liver, bone, lung, and brain. We discussed about paraneoplastic endocrine symptoms and complications, and something that's again very specific for the renal cell carcinoma is the Stauffer Syndrome. And this is basically paraneoplastic nephrogenic hepatomegaly. And this basically describes a dysfunction, deranged liver function in absence of metastases. So This can result in hepatomegaly, cholestasis, cholestatic jaundice, and this is thought to be due to increased interleukin-6 levels in the blood. Yeah. Okay, so talking about the prognosis, it very much depends on the stage and spread of the disease. So overall, 5-year survival is in the region of 70%. However, as with any cancer, early detection leads to improved prognosis. And actually survival from metastatic disease has almost doubled since the sunitinib has been introduced. And the overall 5-year survival is now between 30 and 50% in patients with lung metastases. Okay, so let me just take you through the bladder cancer. Again, this is something that's really important to be aware of. So just something to start you thinking about, what is the most common subtype of bladder cancer? Squamous cell carcinoma, transitional cell, or adenocarcinoma? Okay, so the most common subtype of bladder cancer is the transitional cell carcinoma. However, all those types actually represent the subtypes of the bladder cell cancer. Okay, so you would recall that transitional epithelium actually lines pretty much the entirety of your urinary tract, so your renal pelvis, ureters, bladder, and urethra. Transitional cell cancer actually most commonly arises within the bladder itself, and it affects for the majority of bladder cancers, so it's around 90%. It is also known as Urophilia Carcinoma, which is another name you can find it under. It is thought that basically the loss of function of tumor suppressor genes, such as P53 and RB, has been implicated in the cancer arising. And really important that it can actually present as solitary or multifocal lesions. Okay, so as we already said, there's a few different subtypes of the bladder cancer. So papillary cancer basically represents the majority of the causes. And if you were to look at under a microscope specimen, you would find that it usually has superficial sort of finger-like projections, and it's often non-invasive and actually carries a good prognosis. And quite a distant end of the spectrum, we have a flat type, which is basically a type which is lying really flat against the bladder tissue, and it has very prone to invasion, which subsequently leads to poorer prognosis. There's a number of rarer causes for bladder cancer, and those include squamous cell carcinoma, which is sort of around 1 to 7% in the UK. And this one is associated with chronic cystitis, which is secondary to schistosoma infection, which is commonly seen in Egypt, or when people have traveled from Egypt. And there's also adenocarcinoma subtype, which represent the minority, only 2% of patients. Okay, so thinking about some risk factors for transitional cell carcinoma. Increase with age is something that is implicated. So this is most commonly diagnosed in patients between 50 and 80 years old. There is slight male predominance, and it's also linked to family history. Smoking is very heavily implicated in developing bladder cancer, and it's actually associated with 2 to 4-fold increased risk. And this is both for current and ex-smokers, including people who have stopped within 20 years. Bladder cancer is linked to occupational exposure. So this is something to be aware of when you see a patient who's worked in sort of rubber, dye, or textile industry due to their exposure to aromatic amines. It is linked to work in aluminium, coal, and roofing industries, and also painters and hairdressers. And as we discussed before, a more uncommon subtype, squamous cell carcinoma, is linked to schistosoma infection because it basically causes chronic irritation and inflammation to bladder. And as we discussed, it is more common in Egypt. And actually, their bladder cancer is the most common malignancy in males. Okay, so just to go through some clinical features in a systematic way. So your typical patient would present with painless hematuria. It could be either microscopic or macroscopic. So they will either come because they can see blood in the urine, or you would pick it up on a urine dip. Even though the hematuria, it's usually described as painless, at times it can actually cause dysuria, it can cause pain. The patients present with frequency, so they could complain of going to toilet multiple times a day. And they would have constitutional symptoms as well, as with other cancers such as weight loss or pyrexia. When you're examining the patient, you can see palpable suprapubic mass when the case is really advanced. Something to be aware about is that when your patient is presenting with hematuria with chronic bleeding, they could actually be anemic, and you can pick it up clinically as well. For example, they could be pale. Okay. So just something to get you thinking about. You're in a clinic and you see a 50-year-old gentleman who comes for the first time, and he complains for 2 weeks of visible hematuria. So he's passing blood in his urine. You then do a dipstick, and you find that his test is positive for blood, for leukocytes, and for nitrates. So do you think that this patient should be referred to urology on a 2-week wait pathway? Just have a think about that. Okay, so this patient actually does not meet the 2-week wait referral criteria. And if we go to the slide, so this is basically taken from NICE guidance on who you refer on the 2-week wait pathway. You would recall that our patient was 50 years old, so he's in a 45 and over category. He is presenting with visible hematuria. However, on the urine dipsticks, you also found leukocytes and nitrates, which imply that the patient has urinary tract infection. So for those patients, you would need to make sure that you've treated the infection first. And if the bleeding persists after the successful treatment, then you'll think about referring them. Slightly different if your patient is older, over 60 years old. If they have unexplained microscopic hematuria and either dysuria or raised white cell count in the blood, you would want to refer them on. For people who are 60 years old or over, you would actually think about referring them non-urgently to urology if they have recurrent or persistent unexplained urinary tract infections. Okay, thank you. Right, so now think about how you would actually investigate the patient. So you'd start by doing urine dipstick and looking for hematuria. You would then move on to doing some blood tests, so a full blood count to assess the red blood cell levels and for chronic hematuria. So when you do U&E, you can actually find that your patient might be in renal failure, and this is because if the tumor is sat by the bladder outlet, it can actually cause the bladder outflow obstruction, which in turn would basically cause a mass effect and a back pressure on all of your renal system and can lead to renal failure. You would do a bone profile looking for hypercalcemia and raised ALT, which are both indications of bony metastases. And then you would look for LFTs and coagulation, because you want to look for metastases and rule out coagulopathy. The investigation of choice is actually flexible cystoscopy. And from then on, you have a number of imaging modalities to do. So you can go for CT abdomen and pelvis to look for distant metastases. You can do CT urogram to basically image the urinary tract and better visualize the renal parenchyma. However, something to be aware about is it's not often required in patients who have flexible cystoscopy were found to be very low risk. You can then go on to doing pelvic MRI, which is basically done for local staging of the disease. And if the cystoscopy done before suggests that disease has invaded through the muscles, another imaging modality to look for is PET-CT. And this is normally done when you've done the CT before, but there are some unclear findings on it, such as some enlarged lymph nodes that actually have uncertain significance. And you can also do a bone scan if you're suspecting bony metastases, and that will again be done on the basis of bone pain or hypercalcemia. So just looking at the staging of your bladder cancer. So there's basically 4 stages. Stage 1 is basically when the tumor would grow into connective tissue which underlies the bladder, but not into the muscle, so into your lamina propria. Stage 2 is when it's growing to inner or outer muscle layer, but not going through the muscle. Stage 3 is where the tumor would invade through the muscle layer into the perivesical fat. And stage 4 is basically the cancer that grows through bladder wall into other organs. So going for management. So again, it's important to think about how you would treat the tumor based on the stage. So for superficial non-muscle invasive tumors, you have an option of basically doing a transurethral resection of bladder tumor. And this is normally done under general anesthetic with rigid cystoscopy. And post-operatively, the patient would get a dose of intravesical mitomycin C. And then the further management is basically guided by the outcome of the histology that was done at the time. So if the patient is deemed low risk, there is actually no further management required. For patients who are intermediate risk, you would get 6 doses of intravesical mitomycin C. And for high-risk patients, they could either get the intravesical BCG or basically radical cystectomy if they're deemed very high risk. And if you think about cancers that are invading through the muscles, you have the option of performed radical cystectomy with basic neoadjuvant chemotherapy. And patients would normally require urostomy, so ideal conduit. You also have an option of radical radiotherapy with chemotherapy, which can be an alternative to surgery. And then if you think about locally advanced or metastatic disease, the norm is actually to do a chemotherapy, which is cisplatin-based. Some of those patients would actually be would actually receive palliative treatment, and that could be, as we said, because the disease is very advanced or metastasized, or also due to other sort of medical conditions. The general approach is to do radiotherapy for bladder symptoms if curative treatment is just not an option for them. Yeah. Okay, so on a picture on the left, you can actually see an arrow pointing to a bladder wall, which is thickened, and that thickening is very suspicious for actually a bladder carcinoma. And the picture on the right would just remind you of the staging. Okay. A few complications for bladder cancer. For some patients who would actually develop bladder auto-obstruction because of the location of the size of the tumor, they can actually go into urinary retention, which basically can cause obstructive uropathy. And again, this cancer can metastasize, commonly metastasizes to bone, lung, and liver. The overall 5-year survival is in the range of 55%. However, it is significantly decreased if the patient has distant metastases, and the overall survival is in the range of 5%. In general, squamous cell carcinoma, which you would recall is the less common one, is generally associated with a poor prognosis. And as you can see, prognosis is very much related to the stage of the disease. So for your T1 stage, so the cancer that has basically not grown into the muscular layer and beyond it, the 5-year survival is in the range of 85 to 90%. The T2 stage, which is basically cancers that invite superficial or deep muscular dysplasia, it drops around 30 to 45%. T3, which is a tumor extending to the perivesical fat, so it has already reached the muscular layer, the 5-year survival would be in range of 15 to 30%. And as we said, the very advanced cancer invading other organs would give you the 5-year survival in the range of 10%. Fantastic. So thank you so much.